Good morning, everyone. This is Dr. Richard Fleming, and today is Saturday, October 24th, 2020. Hello, everyone. This is Dr. Richard Fleming. Today is Friday, October 23rd, 2020. In the last 24 to 36 hours, there's been a lot of chatter on the internet about the treatments of SARS-CoV-2, or COVID-19, if you will. The two primary topics are remdesivir and hydroxychloroquine. For those of you that are interested in remdesivir, it is apparent that the FDA just approved it based upon information that it had received and the most recent New England Journal of Medicine publication on remdesivir. I want to point out a very critical factor in the analysis of this paper from New England Journal, and that is that the study is based on ordinate outcomes. For those of you who don't know what ordinate means, this would be a good time to go do a little bit of your research, as you call it, by looking up the definition of ordinate on Google or your favorite search engine. An ordinate is a scale upon which you place something. You typically see these on a scale of 1 to 10, 1 to 7, 0 to 10. What's your level of chest pain? You know, people frequently get asked that when they come in the emergency room and they're told on a scale of 1 to 10, it really should be 0 to 10 since 0 is none, 1 is not. But the important thing is that the difference between 0 and 1, 1 and 2, 2 and 3, 3 and 4 is not the same. It's ordinate. It's just a continuum. It's not a measurement. And so the study that was just posted in New England Journal of Medicine is an ordinate study. It's not based upon any actual measurement, which is very subjective. I will tell you that we do have findings that were measured on remdesivir along with the other treatments that will be coming out in the research paper entitled, "Is There a Treatment for SARS-CoV-2?" The other topic that's been discussed is hydroxychloroquine. As most of you know, there's a lot of controversy about this medication. I've encouraged the people that have been using hydroxychloroquine in the outpatient setting to try to obtain some type of clinical study where they measure outcomes. Like the remdesivir study, those individuals have not posed any quantitative measured outcomes, although we do have information again in our study looking at this. Before I hit on the topic of some of the successes and failures of the immunoquinolines, of which the three drugs are primarily hydroxychloroquine, chloroquine, and primaquine, I want to touch on a topic, a conversation that came up in somebody's posting on social media, where they were talking about people being treated with hydroxychloroquine and it potentially killing people. Let's be perfectly clear about what is being discussed. The primary concern about immunoquinolines, as it is with macrolide antibiotics or antipsychotics or a number of other medications, is that these drugs may interfere with the movement of calcium across the membrane of the cells of the heart. When we measure that with an electrocardiogram, that area is called QT because it goes from the Q to the T point on the electrocardiogram. If you don't know what that means, it doesn't matter. If you do think you know what it means, it still doesn't matter. That time interval is corrected, hence the term QTC or corrected QT, based upon the heart rate, and it varies from men to women. In all the studies that have been published talking about the potential concerns for hydroxychloroquine, none of those studies have demonstrated a problem with the rhythm of the heart resulting from changes in QT. It's important to note that inflammation itself, the type of problems occurring with this virus, is also a reason for prolongation of the QT interval. So simply having that inflammation interferes with your being able to sort out whether the drug is causing it or the inflammation or something else. But here's what is key. None of the studies that have been published to date have demonstrated any associated rhythm problems with the heart as a result of this prolongation of the QT interval. There's been no discussion of ventricular tachydysrhythmias and no discussion of torsade de poids, which is a very specific rhythm associated with QT prolongation. That being said, there is absolutely no published data to date that demonstrates that taking hydroxychloroquine or chloroquine or primaquine or any of the other aminoquinolines have produced any type of life-threatening rhythm problem. Now, more importantly, to whether there's any potential treatment benefit. Those individuals that typically treat people as outpatients with hydroxychloroquine claim that they're getting almost 100% success. In our study, we looked at 5 different preparations of aminoquinolines, including hydroxychloroquine and primaquine. And in one of those, we had both drugs combined so that we could tease out the effect. Not every one of these treatment regimens performed equally well. However, they did perform better than no treatment at all based upon the information that we received from the study sites. And at this point in time, I'm trying to come up with a little bit better information for you to give you the actual number. And here we go. Of the individuals that were treated as outpatients with an aminoquinoline, 83.4% of the individuals so treated, according to their physicians taking care of them, responded well to treatment. Now that does mean a 16.6% failure rate. However, when compared with people who received no treatment in the outpatient setting, 47% of those individuals that were studied ended up in the hospital. Now, those are percentages, and I'm not going to share any more of the details about the paper because I'm not going to risk violating any embargo rules, which is the agreement not to talk about the specific details of a research project prior to the journals having an opportunity to be the ones to bring the information forward. But what I am going to say is that the treatment of individuals with these drugs in the outpatient setting demonstrates improvement over no treatment at all based upon the information we've collected. It didn't benefit everybody, but it didn't kill anybody either. For those of you who want to play armchair quarterback as a research scientist or a physician, in the process of reading these studies, you need to have more fundamental knowledge than you're already demonstrating. You're embarrassing yourself on Twitter and other social media platforms, and you pose a threat to the health and security of individuals by claiming to promote information which is confusing and misleading to individuals listening to your rants. Stop practicing science and stop practicing medicine. Start listening to the experts. And the experts are the ones that are publishing quantitative data with actual measured outcomes that make a difference in people living and dying.